So I specialize in lung cancer as we talked, but I'm also very interested in bias, and I have studied several aspects of unconscious bias in medical education and oncology, even we in our groups. The hope of this talk is that no, we only talk about the bias that are out there, but what can you do as an advocate? What can you do as an ally in tools to overcome our unconscious bias? I start this talk explaining that we all have unconscious bias. That is, nobody who's immune to unconscious bias. We have different types associated of how we were raised, educated, and the environment, and also the media. So I'm going to start with an exercise, and I want you don't have to close your eyes, but I want to let your imagination just go away and fly, okay? So I want you to imagine, as I tell you, who do you associate with this? So Wisconsin's new governor. A couple eating at a restaurant. A community leader. And finally, a religious ceremony. You don't have to raise your hands or turn on your camera, but I want to ask you, how many of you imagine Wisconsin's new governor to be a woman of color? And that couple eating in the restaurant, how many of you imagine a same-sex couple? And that community leader, who really put the picture in that community leader, or a middle-aged white woman? And finally, for the ceremony, who imagined a ceremony outside of a Christian religion? So all those things that you went right straight to is part of how we have been formatted, or we have been trained over the years. That certain things look a certain way. I don't look like doctors supposed to look, for example. So of course I had to put a picture of the Packers. So I don't understand football, but I love the analogies of game plans. So we're going to talk about some real world examples, the impact on unconscious bias. How can we practice cultural humility? I'm going to give you some tips to take home, and I'm going to help you become an ally. So unconscious bias can be fatal. We have seen this in the news. We have seen this with police interactions. Unconscious bias can affect patients' care. The stereotype that we have in our head will determine how we interact with patients. And in part is what we have been taught, of what we have experienced through our lives. But I want you to be clear that unconscious bias can be fatal. So what are these unconscious bias that keep talking about, people talking about? Well, in part are based from a lot of stereotypes and also certain beliefs. But the negative unconscious bias are negative associations that can lead to people in danger, like we have seen it. Think that somebody may be underqualified, or just seeing faults that don't exist because that person is in that stereotype. Unconscious bias is so powerful that when I enter a patient's room, my age, my gender, my ethnicity, and my accent enter before any of my titles, any of the publication of that beautiful introduction I just had. That follows me first. And I'm not here to make you feel comfortable. I'm not here to, talk about how great we're doing, how much we're improving, because we have a lot of room for improvement. So my goal is not to make you comfortable. My goal is to help you become an ally. And you don't have to be a certain group to become an ally. Anybody can be an ally for another group that has been marginalized. I come from a place of privilege. I'm an ND faculty and a university. So I can be an ally for somebody who's in the community, for a medical trainee. So we all can be allies to someone. It doesn't have to be a specific group. And if we continue to have the same conversations, we're going to continue to have the same problems 20 years from now. So let's all become uncomfortable together. So as we talk about unconscious bias, one of the aspects about unconscious bias is that overrides rational decisions or rational thinking. Let's talk about what's happening right now and what happened in the summer of 2020. We're in the middle of a pandemic, so we're very stressed out. Challenges with the administration, the political administrations. And there's a second pandemic, which is racism. So all of that we're still in a constant status of stress. And that makes your unconscious bias just flare. Because you're very stressed out, when you're sleep deprived, when you haven't eaten well. Those are stereotypes, those bias helps you set up people and circumstances and environments in certain pockets to make decisions very, very fast. So right now, we're all at higher risk to be in, making decisions based on those stereotypes, those setups in our brain. So we make one decision every 2.5 seconds. And that's what we have created these pockets of in our brain about what things are associated with another group. We make decisions after decisions. Sometimes you can have developed decisions fatigue, in which you decide what you do in the morning. And if you're a physician, you make so many decisions during the day. And at the end of the day, you're exhausted. And that's when, making rapid decisions is convenient. And I'm going to talk about a phenomenon that shows how unconscious bias is present for many people in their daily basis. And this comes from a study in a movement called Walk While Black. A study done in Tennessee by the University of Tennessee and Vanderbilt shows that when you have an African-American or Black person trying to cross the street, it takes them 3 times longer, in some cases up to 7 times, for a car to stop for them. This is a reminder daily when you're crossing the street. We have a lot of these crosswalks here at the university. So for some people, just crossing the street is a reminder that they have been put in a label. And the higher the socioeconomic status of the neighborhood, the longer the person of color needed to wait for a car to stop and then crossing the street. So first impressions is something that I continue to say you have to work in the first impressions. Well, first impressions are mostly based on unconscious bias. Because we see somebody, we haven't interacted with that person, and we already put it in that little box. So when you meet somebody, I want to ask you to think, let me just get to know this person. So I have a Spanish accent. I always make fun of my accent, probably as a way of coping. But sometimes it's associated with me not being smart and being put in a label that should be undereducated. So that's a first impression. Hair. Hair is something that has been stipulated to be a first impression. So if you have my hair straight, often I'm told I'm more professional. And that's just unconscious bias because, curly hair is not associated, because curly hair is associated with Blackness and other races that we're slowly joining the workforce, like the medical workforce. So we're going to talk about different types of bias. And I want you to think in a scenario in which your personal experience was affected by this. So affinity bias is we tend to like the people that look like us, right? We tend to pull the people that look like us. And that's very common in hiring committees. People are most likely to hire people that look and sound like them. And that's the problem about diversity. We tend to pull our own people. And as part of our affinity bias, we feel more comfortable with that. But that doesn't help us grow as humans. If you continue to work with, interact with the same people, are you really amplifying your experiences? So think about a scenario in which affinity bias affected you in a negative way and a positive way. So as we talk, the first barrier for inclusion is affinity bias. We tend to feel more comfortable around our own people, around the people that have same background, but we all can find something in common. Medical school pedigree is also something very common, and it can happen not only for medical school, it can happen for any schools. Oh, you went to so and so, I like you more. And it also can affect patient care. You're most likely to like doctors that sound and look like you. but not all doctors, right? No, all minority doctors can take care of all minority patients or underrepresented groups, and the same way around. And this is an example of what affinity bias is. I have been presented with this situation. Other people has been presented with this situation. So, and this is why unconscious bias enters the room before your titles too, and before you have the opportunity to prove that you're a good doctor. I still remember being in a hospital in the Northeast and a patient requesting that a male doctor would see him because women don't supposed to be doctors. And that was like, I graduated first on my class. I have these high scores. I did everything by the book, but I was still being discriminated just for the fact of being a woman. So this is a type of affinity bias. That patient felt more comfortable with a male doctor. There are things that we can accommodate for, but if it's bland discrimination, the patients need to be educated. And code of conduct needs to be shared with patients. Because affinity bias should not lead to discrimination. Yes, you can feel more comfortable with this certain provider. And there's some aspects that can be accommodated, but not because women shouldn't be doctors. So contrast bias is an aspect in which we compare one thing to another, and we forget most of the things as a merit. And this happens a lot with scores, like test scores. It can be your NCAT, it can be your USMLE test scores, or any scores that you may pass, go to engineering school, or that you go to any schools. We tend to sometimes selection committees to focus on that and forget the application as a whole. So we compare applicants based on one number. And that's called contrast bias. We forget that the whole application has other merits. Somebody could have been a community leader. Somebody could have, different ways to get to medical school or to get engineering school, law school. And that also deserves merit. So think a way in which we're compared to somebody only by one thing. That doesn't define you as a scientist, individual, person. And I'm going to share this story because Cristal allowed me to share this story. And I'm sharing it because it's very personal to us. So 4 years ago, she walked out of the UW-Madison pre-med advising office with tears, thinking that she will never be a doctor because she was a first-generation college student from low socioeconomic status, a Latina from Chicago whose grades didn't make the cut. But fast forward, she's actually now a second-year medical student. So this is the effect unconscious bias can have in people's career. So if you didn't persevere, which it can be the majority of people, then she won't become a doctor because her scores were being compared with another score. So that's contrast bias. But Cristal has been a community leader. She has worked with several organizations. She has done a lot of other things that define her as a good applicant. So when we see the applications as a whole, we can actually increase the diversity in the recruitment of underrepresented groups in medicine and any other arms, like any other part of science, engineering, math, anything. We have to see them as a whole. And this happens in our neighborhood. This happens in our backyard. So gender bias for many people here is not new. We tend to think that one gender may be better than another gender. There are many gender bias negative associated with women, but they're also associated with men. So when my husband, in the middle of the pandemic, he used to go grocery shopping, and people will always ask him, why are you cooking today? No, why is the wife cooking today? And my husband's like, I also know how to cook. Like the association that only the wife can cook and then men are not allowed to. So there are different types of gender bias. And it's also important that we mention there are non-binary genders. And that is actually even worse, as people are less familiar with non-binary genders. The gender is a self-identification, and everybody is allowed to identify with one gender or another or none. And then as we are talking more about non-binary genders, there's more and more bias against them. So it's important to know that we're not only talking about white and black, we're talking about also people that don't identify with either of those two colors. So in the medical world, there's been many, many, many articles about how gender bias has affected women. As per now, there's around $100,000 gap of salary from people that train the same, that work the same. And based on some data published over the last 3 to 4 years, female physicians are most likely to spend more time with the patient, but they still get paid less. And there's some, adjectives that are associated with one gender versus the other. And the most common one is like, oh, she's so aggressive, when in fact, it's just assertive. So there are also, stereotypes associated with men, and these tend to bring the gender bias that we have associated. Yesterday was International Women's Day. I know a lot of people post a lot of things about supporting women. And ironically, there were a lot of posts for a lot of institutions and social media that have gender bias in their description of these leaders that they were trying to highlight. She's gracious, caring. And then you go back 2 days later or 2 days before when they're describing the male partner and they're like, he's a leader, right? So, the whole adjectives that associate one gender versus the other is how we describe and how this can affect applications, grants, and the perception of patients or review committees. I'm going to tell you a story about how unconscious bias and how I study unconscious bias. So I'm in social media. Many of you know that. I find social media, if you use smartly, can be a great tool. So I was in a meeting, the largest oncology meeting in the world. It's 45,000 people. It's like Coachella for oncologists. And I noticed that women were less likely to be introduced by their professional title. I put a Twitter poll, and then we did a study. And we showed that everybody is a doctor, so PhDs, MDs, and this is a career milestone to be talking at ASCO, giving an auto presentation. And we find out after reviewing 2,500 introductions that women were less likely to be introduced by their professional title, meaning Dr. Duma, compared to the male speakers, and they were most likely to be introduced by their first name, Narjust. And that prompted a publication in one of the journals with the highest impact factor in oncology, but it documented something that we have been talking about for years, and how this unconscious bias affects how you're introduced despite you having all the titles. And that affects how the audience sees you and invalidates your accomplishment in your data. And as the data was presented in this meeting in 2019, the day before, one of my colleagues shared the data. And then for the first time, I was attacked for showing the data that showed that like my gender was not being addressed appropriately. And messages like, oh, you were a good researcher until now, reach my email, reach my social media accounts. People will find my email and send me messages like, you're just cherry picking the data. You're trying to divide the society. And that's what I tell you, we have to be uncomfortable to approach change. If we were not uncomfortable, then we're going to be where we have been before. And, the emails came, then the publication happened. But thanks to that, we developed the language of respect that now has been adopted for over 8 societies, now 9 as per yesterday. And is now being shared like in groups like the Australian Medical Oncology Society. Every chair, every speaker is given the language of respect, and which assures that we help improve this unconscious bias and give them instructions. And some conferences, actually we have created a template in which people can just write the name of the person and it has the doctor right in front to help with that. Because if we all train the same, we all should receive the same type of introduction. And then it's not trying to be, oh, I want to be the doctor. It's like, sure, if you want to introduce me by my first name, everybody else in this podium, regardless of gender, race, background, should be introduced the same. But why am I being introduced as Narju and everybody else is introduced by their professional title? It's about equity. And it also exists gender bias of women against women, and it has to do a lot with, children, a lot with some life or career decisions. So it's not a thing about men versus women or women versus men or binary versus non-binary genders. We tend to, judge the people that do things different that we do. So Horn's bias is when we focus on one negative characteristic. Like one negative characteristic that follows me everywhere is my age. And ironically, I thought being younger was a good thing, but in medicine it's not. It's associated with you should know more if you're older. So we focus on one negative thing. Oh, Dr. Duma doesn't know that. She's under 40. So when we focus one negative thing and we forget about the individual and everything else they bring to the table. Age bias, as we talk, is it too old, too young? There are people entering careers at all different phases of their life. That is, we shouldn't hold people by their age. And this picture really, really marked me when I saw it the first time. This patient is 89, and she's asking people to talk to her like a regular person. She's strong. You don't have to babysit, or many or older adults are capable of making decisions. They have been around longer than us. So it goes both ways, right? Are you too old or too young? So unconscious bias in medicine, quick, it has been showed that many healthcare providers have unconscious bias. There's a meta-analysis that shows that we mostly have unconscious bias against people of color or low socioeconomic status or with a language barrier. And think about it, who needs the providers the most? The people who have limited resources and the people that may not understand you, but we have negative bias against them. There's also physicians show bias, particularly for pain. I think is something very challenging. It has been proven in oncology. So these patients have metastatic cancer, and there has been differences in pain prescriptions between people of color and people that don't represent underrepresented or minority group. And there has been even studies about fractures in the ER in which you have a reason of pain. So unconscious bias affects all levels of medicine, all levels of care. This is one of the papers I have published about how unconscious bias affects, are you presenting a patient with a clinical trial? In many cases, the clinical trial is the best treatment option, but there are perceptions that people of color, don't trust the healthcare system. But they don't trust the healthcare system for many, many reasons, right? We have given historical events not to trust the healthcare system. So it is a job to improve that trust. And not only the people of color need to improve the people of color trust the healthcare system, everybody else needs to be involved. And now I'm going to tell you a story. I strongly believe in the power of storytelling. You're more likely to remember a story than to remember numbers or graphs. So I'm going to tell you my story, and you can feel free to share it as much as little as you want. So this is me as a second-year resident in the CCU at Rutgers. I came to this country and come from a privileged background and a fourth-generation doctor. But as soon as I landed in the US, I was put in a label of being the Latina. Back home, everybody's Latino, so it was challenging because I was supposed to be this or do that. And it was very difficult because I hidden key parts of my personality during my training, tried to fit in. Because when I was telling jokes about my abuelita, my grandma, people won't get it. Or, oh yeah, that's so unusual. So that led to clinical depression during my training because I was hiding so many parts of my personality to fit in, to help with the unconscious bias. Because when I look left and right, people didn't look or sounded like me. So that led to many challenges, but I was a highly functional depressed individual, but still, I was trying to fit a box that didn't belong. Comments like, oh, you don't look old enough to be a doctor. Oh, your English is so good. When you get one comment a day, maybe bearable, but when you get hundreds of them, it's just sometimes it feels like exhausting just to deal only with the comments. Those are microaggressions. So for the first time in my life, I felt like my white coat didn't fit. I was raised by nurses. My mom was a single mother surgeon. So she used to let me in the PACU for the nurses to fit me and care for me. But I didn't fit here. So I felt like maybe medicine wasn't for me. But one day I'm like, I just walk up and say, I'm gonna wear my yellow dress. Because I used to wear black all the time because I was told I was too colorful for a doctor. And we founded the Latinas in Medicine with Dr. Maura Pinzon and Brianna Christophers, who's a medical student. Now the group is over 5,000 members. And the goal is to help with the isolation because often, like this picture here in the bottom, we're the only Latina. But if you find another one, it can be helpful. So we created ribbons for conferences, and people are going to kindergartens to show the next generation that it's possible because you can do what you can see. And finally, after everything, and I feel very comfortable showing you these pictures in which are not touch up and professional because we are more than our profession and we're here to change the status quo. Because the status quo is not working for a large proportion of the population. I want to make sure that you hear stories from other people besides me. So I'm going to play some of my friends, collaborators, colleagues' stories. And Cheryl, let me know if you cannot hear, okay?
Yep. You're from the Caribbean, but you're so well spoken. I bet you'll get the job because you're a woman and you're Black. Oh, your hair looks so nice when it's straight. It's so professional. Calm down. You're making me uncomfortable. No offense, but you're just not the right fit. We don't have a job for you. These are just some of the microaggressions that I have experienced over the last several years. From colleagues, from friends, from patients, from leaders. These are the things that, when you think about them being internalized, lead to feeling like you do not belong.
Hello, everybody. I'm Armando de Alba Rosales, MD and PhD candidate, and an assistant professor from the University of Nebraska Medical Center. So the way how unconscious bias and racism has impacted me as a young physician, one of the clear examples is when I am in a meeting and I have to bring an uncomfortable conversation, usually there is someone who tries to rephrase what I have to say. They actually say something like, oh, what Armando tried to say was, and they even change the message or even make it softer or disaccredit what I have to say. So a little background here, my native language is Spanish. I'm originally from Mexico. And culturally, we have a lot of words to express sometimes a message when we have to deliver a message. But we do it because it's a polite way to do it in our culture. So in that situation, what I was describing, I have to rephrase and retake the comment and make the message again. So this is just one clear example of how some other people interpret or even disaccredit what I have to say in a meeting. Thank you, and I hope you enjoyed this session. Hello, everyone.
Happy to talk about this topic about how unconscious bias, racism, and sexism affected me as an early career faculty and trainee. I think the effects of these microaggressions and multiple isms caused a lot of stress and a lot of imposter syndrome early on in my career, a lot of lost opportunities to move up or lean in or step into the process. But I've learned from sponsors and from mentors, kept my head up and kept reaching for the stars.
So the impact on unconscious bias goes beyond this. It affects letters of recommendation, interviews, hiring, and leads to isolation. Because you feel like, you're being told so many times you're so Latina that you start questioning, is like, I'm really that Latina? And honestly, I don't know what so Latina means still. So what fits into unconscious bias in academia in general? This is not only residency for any aspects of academia. That scores, your school for degree, where do you go to undergrad, where do you go to grad school, immigration status, gender and sexual orientation fits in people's unconscious bias, and socioeconomic status and family background. Oh, you're a fourth generation doctor. It's actually a label that helps, but that also doesn't help the people that are first generation. So let's talk about cultural humility so we can talk about how you can become an ally. So the cultural humility term was developed by Dr. Tiralon and Dr. Murray Garcia in 1998 when they were trying to find a multicultural intervention for healthcare professionals in LA. This happens after the LA riots and police brutality and challenges of how racism was affecting patient care. So cultural humility, this is not a talk about cultural humility that takes a workshop and time, and there are many aspects of cultural humility that are evolving and improving. But what I like about cultural humility is that it's a lifelong commitment about learning. And I'm going to tell you a story about this weekend. So I was posting in social media that it's very important that we learn preferred pronouns. And I type preferred pronouns, and that's the wrong way to say it. And the value or principle of cultural humility that you are a lifelong commitment to learning. So one of my friends sent me a text that's like, NJ is no preferred pronouns because gender for some subgroups is not a choice. It's how that's how they identify, how they feel in their skin. So particularly for the transsexual community. So I learned that's just pronouns, that the term preferred pronouns is no applicable anymore. And it's just showing that it's a choice when it's not. So the lifelong commitment on learning and growing, and thank people for teaching you that and showing that you don't know everything. And that's what I'm sharing that story, because I don't have to know everything about this. And I made a mistake about using preferred pronouns when in fact many of these things are not a choice. It's how our friends and people identify and how they feel in their skin. It's also about fixing. I strongly believe in fixing. If we continue complaining, we don't do anything. That's a challenge. And that was about the speaker introductions. We created guidelines. We help people. We work with the societies. And accountability is very important. The institution and ourselves. And also to have mutual respect for our colleagues and our patients and whoever we interact with. There's a difference between cultural humility and cultural competency. I'm not a big fan of cultural competency because you cannot become competent in somebody's culture. I'm a Latina, but Latinos come in every flavor, type, different countries and everything. It's hard for me to become competent in every cultural aspect. The Mexican culture is different to the Venezuelan culture where I grew up. So cultural humility is as you grow and you understand that everybody has something to bring to the table. And I'm going to tell you this story about, and you can watch the video later here at the YouTube video, in which there's a Latinx patient that's being taken care of by an African-American nurse. The patient is complaining about pain. And a Latinx doctor walks by and asks the nurse. And the nurse says, I completed all my modules about cultural competency. I know Latinos are most likely to complain of pain. But that person that was in the stretcher didn't speak English, and she was in severe pain. So the cultural competency gives you the sense that you're competent because you learn about it and you read. But in fact, there are many different aspects of culture for a person. Cultural humility comes from the places like, are you in pain? What's going on? We ask and we try to learn from each other. Another example of cultural humility is this. For example, this is from the Asian Pacific Islander Domestic Violence Resource Project. Something that's against cultural competency is to say, you're Japanese, you must love sushi. So that's an assumption, right? What about if we ask, what is your background? How do you self-identify? And how do you feel about sushi? So you're coming from a place of wondering, do you like sushi? Instead of just assuming you do, or that person does. So it's a place of wonder instead of just making assumptions. And also, if you don't want to ask somebody background, you don't have to. Like, it depends on the relationship, but I think, don't where you're from is a microaggression too. So now let's talk about what can you learn from this talk to fight your own unconscious bias. The first thing is just question stereotypes. And I actually love to do this because it's like going to the gym. The first time you question a stereotype is like the first day after going to the gym, you're like sore. You're not really sure if the gym is good for you, right? Because you're like confronted somebody or just question something. But as you keep going to the gym, if you do, and you keep questioning stereotypes, you get better at it. Same with microaggressions. So if somebody says, oh, the girls can be builders, oh, girls can do science, or they cannot do math, you need to ask them, can they? Have you met every girl in the entire wide world and you really think they can do math? What makes you think that? What data supported that? That person will think again, hopefully, about that stereotype. And if it is stereotypes in general, just question it all. Because stereotypes are there to be broken. Second thing for your toolkit is to diversify your experiences. With COVID, it has been challenging. We're doing remote everything. But hopefully as we open up, and now just in general with Zoom, there is Meetup, which is an app that you can meet friends. It's not about dating, it's about meeting friends. To diversify what you learn from others, so you don't live in this narrow channel that this is how we do it. This is how it's supposed to do. Because that's what you do, but doesn't mean everybody does like that. So asking people about their experiences, hearing their stories. Oh, you survived breast cancer? Can you tell me how was that? Oh, this is how you make this food? Okay. Learn about it, diversify so you can see what is out there. Traveling is the best way to diversify your experiences. Hopefully in 2022, you may be able to, but learning for other cultures without, of course, still, adapting, but learning how other people do things helps you kind of break those stereotypes. And you can just talk to your friends. Like, how do you cook this? How do your family does this? Because we in the United States, we have a beautiful diversity. So just go out there and learn from other people, and they can learn from you. There is no one culture that's better than another. And as we enrich each other and we learn from each other, we just become better humans in general. So something important about all of this that goes back to cultural humility is about reflecting. We all have unconscious bias. If we come from the place, it's like, I use all the pronouns and I do everything right, it would be hard. We do. So the Harvard Medical School has an unconscious bias test that I have taken 11 times, and I still have same unconscious bias, which is for women who stay home. My mom was a surgeon. My mom is a surgeon. My grandma was a pediatrician. So for me, the norm is that women go to medical school. So I have bias against people who stay home. So understanding where your own bias will help you, but you have to do self-reflection. Now that the weather is nice, self-reflection goes great with a walk. To understand what you feel uncomfortable and what do you think is unusual, and how you ever have done a microaggression or affected somebody. And this is something we cannot do for you, but you can do, and it just makes you understand where are the limitations. Or I have bias against stay-home moms. So when my sister-in-law talks about her challenges about stay home, I listen and I try not to come out and say, oh, but you don't work, because that's a full-time job. And it's not what I'm familiar with, but it's also something that I'm learning about. And it sounds very exhausting, to be honest with you. So the gut feeling, I keep hearing, oh, it just doesn't give me a good gut feeling. But gut feeling is just unconscious bias. It's about stereotypes and what you feel comfortable with. At least you decide to eat sushi in a gas station, that's a different type of gut feeling, okay? That you should trust that one. That's different. But the gut feeling about people or about situations is associated with unconscious bias because it's just something that's not backing up by data or your rational thinking. It's about, that person is different than me, doesn't give me a good gut feeling. That person didn't train like I did. She talks differently, or he talks differently, or it talks differently. So I don't like gut feelings. Every time somebody has a gut feeling, at least it's a GI symptom, like, some gastrointestinal challenges, go beyond your gut feeling. Talk to your brain to see if that gut feeling is backed up by data. So what about my diversity training? That one that you were mandatory to do? I just did my unconscious bias training and I was like, these just perpetuate more biases, because actually what it does is that increases stereotypes. It puts a picture of the African-American Black person and the things that you shouldn't say. But then generates associations. And also for the majority group, they feel like everything is fair now. I did my diversity training, we're all good. The scale is balanced, we're good. It's not true. Diversity training 2 modules has not made anybody an active ally. The training should be within self with some of the principles of culture humility that you can apply to it. And it has been proven that these diversity trainings and modules that you skip may actually worsen your behavior towards minorities. And as I say, no mandatory module has made anybody an active ally. That somebody just like skips, reads the whole PowerPoint, it's like, yes. So how to become an active ally? And I'm gonna share the voices of people that have helped me through my career, that some of them are part of the majority group, some of them are part of the minority group in medicine, but this applies to anybody. So here's some of their tips, because you can learn from them and you can also try to find your own allies. We all need allies and we all can be allies. All right, next video. All right, let's do this. This is Dr. Don Deason. If you're in TikTok, you should follow him.
So what exactly does it mean to be an ally in medicine? To me, it starts by admitting none of us are perfect and that we all have our biases. Each day, I learn what mine are, and each day, I learn how to mitigate them. And I think that's critical. See, self-reflection means asking yourself, how can I do better? But it also means going beyond that. It means not being afraid to speak up when something doesn't sit right. And it means proactively treating everyone equally, no matter race, sexual orientation, or gender. Finally, it means being a voice for equity in your division, department, and institution. Chris Gardner is credited as saying, strong people stand up for themselves. Stronger people, they stand up for others.
He's one of my coolest friends for sure. And you may know these gentlemen here, Dr. Lubner from UW.
We're all familiar with the data surrounding the social determinants of health. They affect our patients' ability to afford, access, and receive care, and they lead to inferior outcomes if ignored. Similarly, there are social determinants to career success, and failing to recognize, confront, and improve the existing biases in our workplace is a missed opportunity. Our colleagues can feel at a minimum isolated and alone, and at a grim maximum threatened, unwelcome at work, and subsequently leave the field. It takes thought and effort to be an ally, but it is rewarding to see the impact of acknowledging, amplifying, and supporting your colleagues. Because equity is not a zero-sum game. It is not giving something up to have someone else succeed. And giving people an added voice from whatever position you hold helps your colleagues feel valued and helps mitigate burnout. Being an ally for equity helps you too. I've learned so much that I was previously unaware of in my own workplace, and I think that awareness has made me a better colleague, a better fellowship director, and ultimately a better doctor.
Hi, everyone. My name is Toby Campbell. I'm a thoracic oncologist at the University of Wisconsin. I'm also professor and chief of the palliative care section, and I have been working on mentoring as a professional development goal over the past couple of years, especially working with underrepresented minorities in medicine. And I have 3 simple tips to share with you. The first thing that I've learned is to be really careful about checking in with my mentees about how things are going. We've often heard that it takes twice as much work to accomplish the same tasks as someone who looks like me, who's white and male. And so my experience is often different. And it's important that I check in with each individual person as an individual to understand what their goals are, how things are going, and what things are like for them. Thing number 2 is to ahead of time agree on strategies for good allyship with my mentees. That might look like interactions that we have together in meetings or with outside groups in which we are working in concert with one another and which I have consent to function as an ally. And thing number 3 is to be strategic and careful about sponsorship. When I do that, how I do that, where I do that. Small things like in a meeting saying, I agree with Dr. Duma, without feeling compelled to add anything more, can go a long way to promoting our mentees forward. Thanks. Hi, everyone.
So a few other tips to become an ally is, be aware of pronouns, use diverse pictures and experiences, and you can actually help when somebody is being interactive in a meeting. I think Zoom has allowed for interactions to happen easier, and I think in person may be more challenging, but you can actually stop and say, I'm sorry, you just interrupted Dr. Perez. And what Dr. Campbell mentioned is that he is my ally because we're in a meeting, and he sometimes just says, I agree with Dr. Duma, and that has such a strength to help me balance the field because I have the approval of somebody who's more senior and is part of the majority group. So these are a few things you can do to help and become an ally. I think other is to bring other people to the table, like bring people into the conversations in a meeting or in a general conversation, like Narjust, what do you think we should do next? You have that power to bring that person that may be in a corner that hasn't been involved in the conversation. If that person doesn't want to be involved, but if you don't want to be involved and they're not giving a voice, you can do that. And that doesn't require a lot of time. Also, manos. Manos are panels in which are all males. And you can call that out and mention and say, I don't feel comfortable, men and women, I don't feel comfortable being in this panel because it lacks diversity in gender, race, of subject matters. You can advocate for women, people of color, members of other underrepresented groups to become keynote speakers, to be panelists, to recommend people forward. And I had the pleasure last year to give a presentation for the month of learning for women in UW about microaggressions. This talk is a 45-minute talk on how to stop a microaggression. Active allies sponsor means you give somebody an opportunity and you put your name on the line. It means I cannot give this talk, but a Dr. Duma can give this talk. Mentors, like, why are you doing? Can I check in on you? You advocate. I think we should include more women in this panel. And you take action. You develop the panel. You invite the person to the talk. You invite them to the project. All of those things that you can do as an active ally. And the badge of ally is earned. Put it in your social media profile. Doesn't make you an ally. You have to earn that. And finally, I will ask all of you to use your privilege to create equity. We all have privilege in a way or another way. I have privilege as a physician, faculty, a woman that speaks English, a woman we are stable immigration status. So I'm using that privilege to mentor the next generation, to treat my patients as we fighting my own unconscious bias every day. We all have a type of privilege because we have food on the table, because we have a car. Many people don't, not only in the United States, but outside of here. So use your privilege to create equity. Thank you, everybody, for your time. I appreciate
Thank you, Dr.
you so
Duma.
much.